All right, hello everyone, and welcome to Silicon Flatiron Center's first ever virtual conference. My name is Craig Konnoth, and I am an associate professor at Colorado Law School, where I also run the Health Law Certificate. While the center has regularly held health conferences, this is also the first conference of the newly official Health Data and Technology Initiative, of which I am privileged to be the faculty director. Thank you to everyone for joining us during these circumstances. Now, even without the situation we have found ourselves in the last few months, this is an exciting time to be working in the field of health data and technology regulation. In the waning days of 2016, Congress passed and the President signed the 21st Century Cures Act, among the most, if not the most, far-reaching set of provisions affecting health data and technology. And we could spend days discussing its numerous topics, which range from FDA regulation of technology and software, precision medicine, Project BioShield, antimicrobial resistance, and telehealth. So today we can only focus on one aspect of the Act, creating an approach to promote health data transmission and access in a way that can promote patient treatment, health system improvement, public health, and research, while at the same time maintaining patient privacy and autonomy. The Act promotes these goals by regulating at two levels, and those two levels correspond to our two main panels. First, at the micro level, it regulates electronic health records to promote the way in which they can share data. It limits data blocking practices and promotes the use of application programming interfaces so that EHR data can be fed into apps for easy access and analysis by all stakeholders. HHS released a rule less than a month ago that addresses this very issue. That micro-level regulation of EHRs is the topic of the first panel. Second, Cures regulates at a macro level by requiring HHS to engage in developing a national health information network. It is along this national superhighway that patient information can hopefully travel no matter the source and destination. To that end, over the last year and a half, HHS has developed what it calls a Trusted Exchange Framework and Common Agreement, TEFCA for short. TEFCA will provide the framework and rules that will define this national network. The national network and its framework will be the topic of the second panel. Finally, we had scheduled a keynote by our very own Congresswoman Diana DeGette, who was one of the two co-sponsors of the Cures Act in the House of Representatives. Unfortunately, given the times we live in, due to unforeseen circumstances, we were informed this morning that Congresswoman DeGette could not be here. Before we embark on the Act itself, however, the recent events that we are living in have shown the importance of access to health data for all the purposes that the Cures Act envisages: patient treatment, health system improvement, research, and public health. The coronavirus crisis needs no introduction. Rather, I will simply introduce our first panel, a panel of experts who are here to discuss the use of health data and EHRs during the coronavirus crisis, and whom I'm indebted to for coming together and responding so quickly to my request just in the last 2 weeks to join us on this panel. Our first panelist is Ann Boyer. She is the Chief Medical Information Officer at Denver Health and an assistant professor at the Division of Pediatrics at the University of Colorado School of Medicine. She is board certified in both pediatrics and clinical informatics and has led Denver Health through some of the health data regulatory adventures of the last several years. Iliana Peters is a shareholder at Polsinelli, DC, and is formerly the acting deputy director for HIPAA at the Department of Health and Human Services, Office for Civil Rights. She is an authority on numerous health data regulation issues, including HIPAA, the HITECH Act, the 21st Century Cures Act, the Genetic Information Non-Discrimination Act, the Privacy Act, and emerging cyber threats to health data. Finally, Niam Yaraghi is an assistant professor of operations and information management at the University of Connecticut's School of Business and a non-resident fellow in the Brookings Institution Center for Technology and Innovation. His research is focused on the economics of health information technologies and the impact of business models and policy efforts on cost and quality of care. Before we begin, just one housekeeping item. So you will see your Zoom interface in front of you, and you will see two different avenues through which you can ask questions. We request that you ask questions through the Q&A interface, because that way we can ensure that all your questions are collected in one place, and we can keep track of your excellent questions and get it to the panelists. So the way this is going to work is I'm going to pose a few questions to the panelists, and after that we'll turn to Q&A. So I'm going to begin with Anne. Anne, thank you so much for being here. My first question really is, what tools have you found the most useful so far in your health data toolbox to deal with the coronavirus 19 epidemic that we have seen?
Yeah, absolutely. As you said, coronavirus needs no introduction. For the last month now, we've been working very quickly to implement a lot of different things within Denver Health, where I work, as well as throughout the nation. Most health systems are doing pretty much the same thing. I think the biggest thing I call out is telehealth. In this era where all of a sudden all of us are having this meeting remotely, patient care has largely moved remote as well. I think it has been very impressive how systems who've never touched telehealth before have moved very quickly to providing 80 to 90% of their care virtually, at least in the outpatient space. We as an organization at Denver Health have never really had a reason to do telehealth because we couldn't be reimbursed for it, being a federally qualified health center. And this was our impetus to pretty much get our telehealth platform up and running within about a week and a half. And so we've moved almost all ambulatory care to telephone visits first, because that was the easiest to stand up. And then video visits launched last week, and we're hoping by the end of the week to have most of our kind of non-essential in-person visits moved to video visits. Talking to most others in the Front Range, that's exactly what they've done as well. My husband is a physician for Kaiser, and so I get to listen in on their phone calls at night. They too are probably 80 to 90 or more percent virtual at this point. So I think that that's kind of the biggest thing to call out, because that's how most of us have changed in our practices. I think the other interesting thing is just the rapid deployment of all tools. So normally in health IT, at least at the organization level, it's committee after committee, policy after policy, trying to get agreement on how we deploy things. And coronavirus has made us run a lot quicker in how we deploy things. The first weekend we were fighting this, we pushed 1,000 changes into our EMR over the weekend to be able to support our providers and to deliver care to our patients. So things like 15 languages of translations of after visit instructions for our patients who've come in. Orders, as the orders were changing very quickly as to what order you would place to order the coronavirus testing. We had to change that about 10 times in the first week because we were sending things to different places, and then we had our in-house testing up and running. Different decision support tools for providers. We put 2 more in over the weekend when patients would get testing but not get put on the right precautions. So we were able to very quickly, within a matter of hours, make sure everyone was being alerted to the fact that someone was tested and need to have specific precautions. Normally these are things that go through committee after committee, and it takes a really long time to get stood up. But we're acting a lot more nimbly to respond to this in kind of an appropriate way. And I think the other thing I wanted to call out was collaboration. So a lot of, at least in the Denver area, most of our major health systems are on Epic. And as an EMR, they've really promoted collaboration across the country for delivering the right care to our patients. And so we've had multiple organizations who have very large IT departments create incredible tools for patient care delivery, gave it to Epic or worked in collaboration with Epic. And then within a week, that was delivered to all other systems so that we could use those tools. So things like toolkits that can be pushed out to patients' portals so that the patients can answer questions about their symptoms for coronavirus, and we can respond to that. Those things normally would take each IT department, months and months and months of development time to deliver, but because we were able to share and collaborate, we were able to very quickly take those tools and deliver them to our patients. So I think those are kind of some of the big highlights. I think one other thing I mentioned on our pre-call was how we're communicating with our patients, and it's kind of along the lines of telehealth. So patient care portals are how we're doing a lot of this, and so most systems have some sort of a portal into their health system. It's how we're delivering negative test results to our patients, because we can't call that many patients. We don't have the systems in place to be able to deliver those negative test results quickly. So we try to make sure every patient is signed up for the portal so that when their test results come back, they actually get a push notification of what their results are and have more timely information about what those results were. I think you're on mute.
There we are. I was sure that would happen at some point in the conference. I'm a little disappointed that it happened immediately and by me. So there we are. But so just a quick follow-up question. So so obviously patients have had to use telehealth services. Have they has there been a lot of uptake in terms of the patient portal functionality and other functionalities that have been offered patients and physicians for that matter beyond to use?
Yeah, so at least, I mean, I know our systems data, we've been kind of seeing about a 1% per month increase in our patient portal usage. We have a fairly different population that we take care of here in the metro area. And so we sit at right around 24 to 25% of our patients are on our patient portal. We've been seeing that grow a lot in the last couple of weeks. Unfortunately, the data kind of lags and we only have March data just recently. And so it'll be interesting to see April where we get, because we've really just in the last week and a half started reminding every patient to sign up and asking them to sign up. So we'll see where that goes. What we have seen a lot of is the increase in messaging. So normally on average, we have about 1,000 patient messages, 11,000 patient messages a month that come in as medical advice requests. Those are non-billable visits. Those are just kind of messaging back and forth with your care team. In March, we saw 18,000. So probably almost twice as many messages as we normally see came in the month of March. And again, that's just people reaching out, asking questions, asking for information about their healthcare, sometimes asking for prescription refills. So we've definitely seen an uptick in that usage within our portal, and hearing from other systems, they're also seeing the same kind of thing.
That's very helpful, Anne. Thank you. I'm next going to turn to Niam. Niam, thank you so much for being here. So we've heard a little bit from Anne at how at the clinical level, we're seeing the rollout of various electronic health record and telehealth tools. I was wondering if you can sort of take us up a level and tell us what health systems and developers and the industry itself can do right now to achieve the desired functionality, and indeed, what have they done so far?
Absolutely, great question. And there are a lot of things that many of these health information exchange networks have been doing very recently. I actually reached out to some of them to ask about their efforts. And I was very pleasantly surprised. In New York, for example, one very valuable thing that the HIE in New York City and also in Western New York are both doing are providing clinical data and merging that with the COVID test data to not only public health officials, but also groups of data scientists and physicians and medical researchers in order to help them in their efforts in order to uncover the underlying medical conditions of this disease. I believe that would increase the pace in which we're going to finally reach out to a solution with COVID-19. Or, for example, in Florida, one interesting thing that they are doing is to provide encounter notification for patients that are of high risk of having COVID or to suffer from the complications of COVID upon their patient's visit to the healthcare providers, which, again, I know is very, very valuable for healthcare providers. These are all examples of the things that these health information exchange platforms, whether they are regional ones or they are, the ones that are controlled privately like Epics or Athena are doing. But also, I think the more important impact of COVID-19 in this ecosystem is the fact that it completely changed the whole business perspective of things. If you think about it, for a health information exchange ecosystem to work, there are three major partners: patients, providers, and payers. And before this, we didn't have a lot of success when it comes to interoperability and information exchange. And everybody was really unpleasant and not happy. And government was trying to do everything that it can by rulemaking and, the most recent ones, TEFCA and others, in order to push providers to share data and encourage patients to provide consent for providers to share their data, and also to think about payment plans in order to alleviate the business concerns that providers may have. This COVID-19 have the silver lining of that, I think, is that it have solved all of those problems. As Anne was mentioning, now we see a very sudden increase in the use of patient portals in exchanging data, simply because there is a sudden need for that. To give you an example, we've had this service called Instacart, in which you can order groceries online way before COVID-19, but it was not that popular. And all of a sudden, it has become so popular that you cannot find a delivery window within the next 10 days. And I think the exact same thing, for the exact same reasons, happened for interoperability and health information exchange efforts. COVID-19 created a need so that information exchange is really now meaningful. I am one of the people who have, for a long time, advocating for the fact that the lack of interoperability is not a technical issue, it's more of a political and economic issue. And I think COVID-19 has resolved those things. And I would have never imagined in a million years that we would be sitting in a meeting and I hear these statistics, like, you're doing almost all of your non-COVID-19 visits, virtually. I know, or you have about 20% increase in patients' access to their portals. If you look at meaningful use criteria, one of them is patients' access to portals, and they were saying that as long as one patient accesses your portal for once in a year, okay, one patient once in a year, you're good. And now we see these really promising numbers. Again, shows that patients now see a need to contact their doctors virtually and to have their medical records electronically. And doctors obviously see a need. And the good thing is that CMS has really stepped up and tried to do what it can in order to facilitate this transition. One prime example is that now it allows providers to bill at the same rate of an in-person visit for telehealth, which is great. So I think now you have the government as the biggest payer on board. You also have providers, and you obviously have patients on board. And I think this is a really great opportunity for health IT ecosystem, and specifically HIEs, in order to respond to the sudden demand that there is. And the future is looking bright.
So that's excellent, and you can just sort of imagine the flood of MIPS or would have been meaningful use certifications after this, right? See what we've done. But I guess my question though, my follow-up question would be, do you think that this is going to last? Do you think that, assuming that we get out of this at some point in the near future, that we're going to see this kind of uptake sort of remain, or will people just sort of think, okay, fine, the crisis is past, all of these tools might be rolled back, all of these habits might once more return to what they used to be?
I think it would last for two reasons. First of all, it is such a sudden change that I think psychologically us humans try to cope with these changes by adopting to them and remaining in the same mode that we have been before. That is just my personal opinion. But a more informed opinion would be just to say it depends, just like any other economist would tell you. And it depends on the level of satisfaction of patients and providers with these services. And again, going back to the example of Instacart, I used it for the first time in the couple of days back. And I was really, really surprised at how great that was. And I said, look, I've been wasting like 2 hours every 2 weeks wandering around supermarkets, and this is a big savings in terms of my time, so I may continue to do that going forward. However, had I had a different experience in which that, I couldn't get all the groceries that I ordered or it was not working, then I say, I can't wait for this to end so that I can go to the supermarket and shop personally. So I think to a large extent, it depends on the quality of the service that these platforms provide right now. Is really an important time, and how satisfied patients and providers are with those services. And so that is from the perspective of patients and providers. From the perspective of government, I really find it very unlikely that, for example, CMS, after this thing ends, comes and says, oh, I will no longer pay providers the same rate for telehealth. I think it is a step towards the right direction, and there is a lot of synergy for that. And it would be wrong and very difficult to go back when it comes to the government. And so the government will be there. I think that all the factors looking at the government side are really at a good side. And I think it will be the patients and providers, and hopefully these services are providing good services that are good enough for providers to continue. And the other thing is, because of this sudden explosion of interoperability and data exchange, I think they will soon have many different byproducts of these things, especially the ones that are going to be coming from private sector, not necessarily directly from the healthcare sector. And that would require the continued exchange of data. So one example, for example, could be the devices for monitoring, health monitoring. Some of them have immediate medical necessities and needs. Some others are just for personal health, and people want to use them going forward. So I, for example, think that there is going to be a lot of IoT devices focused on nursing homes and distance monitoring of seniors that are going to rely heavily on clinical data that they obtain from different sources, say it's HIEs or EPIC data sets or whatever. And as soon as they emerge, I think they would again create yet more demand for information exchange. So the optimistic part of me says that this is a change for the good.
Thank you very much, Niam. So Iliana, thank you so much for being here and all your help in pulling all of this together. So we've heard about remote monitoring through IoT devices of nursing homes. We've heard about transmission of data by the New York Department of Public Health of remote patient notifications. What are some of the privacy issues here? And how has privacy law and regulations been affected overall by this crisis?
Yeah, fantastic question. Thanks for having me. I think it's been a challenging time because I think everybody's immediate reaction is that we want to share the most information possible for purposes of ensuring the best outcomes possible for not only patients, but employees and businesses alike. And so, it is sort of my role as the privacy specialist and data security specialist to keep running after people waving my arms and saying, but wait, we want to make sure that we do this in a way that is in fact private and secure to the extent that we can, obviously. So, we've been looking at a lot of different really interesting issues for our clients about, state, federal, and international law applications, both to the collection of data during this crisis for employers, always a very interesting question. And then obviously, and in many cases, most importantly, for these healthcare entities that are on the front lines and providing these important services, both for the healthcare providers and for the vendors who work with telehealth issues or electronic health record issues as business associates under HIPAA. So obviously we've had a lot of questions, and it's obvious to me that the government has also been getting a lot of these questions directly, because there's been just a proliferation of guidance out of HHS as well as other federal and state regulatory agencies and international agencies as well, on the privacy and security implications of this type of crisis. So I wanted to walk through just some highlights of those so people know what's out there and what we're looking at on a daily basis for these entities. But for example, when we're talking about HIPAA covered entities, healthcare providers and health plans, for example, and their business associates, those are telehealth vendors, but also other types of vendors like EHR vendors. There have been a lot of documents recently that talk about the application of HIPAA and what these entities should and should not be doing in terms of keeping data private and secure during this crisis. So importantly, there are in fact 2 notices of enforcement discretion to date, and that's HHS taking the opportunity to highlight issues for the industry and say we are going to approach enforcement differently during this public health crisis. So that is not to say the rules have changed in any specific way, but just that the regulator is going to look differently in enforcement and how they're going to enforce those rules during this crisis. The first notice of enforcement discretion was with regard to telehealth. So as we've already talked about a little bit today, this has become an incredibly important tool for healthcare providers to use to serve patients both with COVID and with other health issues that aren't being able to be seen in person. So as Anne and Niam already mentioned, so much transitioning to telehealth services. And we want to make sure that the best platforms are available for our physicians to use those services. So the HHS Notice of Enforcement Discretion, talks about the fact that to the extent there is a situation where a healthcare provider cannot default to a telehealth vendor that is already a HIPAA business associate, then there may be circumstances where HHS will use its discretion not to impose penalties in those circumstances. So again, the idea here is that we do want to default to private and secure transmissions and communications, and we want to default to HIPAA business associates and business associate agreements, so those telehealth vendors that do in fact comply with the rules and sign business associate agreements. But if there is a situation in which that's just not possible, given the circumstances, the government will use discretion in those circumstances. But the government also makes very clear that this does not mean we can use public-facing technologies. So you have to use a vendor that is reputable, that will in fact keep the data private and secure to the extent possible. Obviously, we're still living in an age of cyber attacks, so that's a whole nother discussion. But we're not talking about the ability of people to use public-facing technologies like Facebook or Instagram to do these sorts of interactions. And again, the default should always be a secure technology with which you have a business associate agreement. So we also get a lot of questions from providers who are like, well, now I can use whatever I want, whenever I want. And really, that is about ensuring that you use the type of vendor that has been already approved by your organization to make sure that it does keep the data private and secure. But if there is a situation where that just can't be done, you need to provide emergency services, or the client that you're working with only has a certain type of technology and you really need to provide that care, then that's a different situation. So, obviously we want to default to private and secure, and then there may be exceptions when we have difficulty doing so in certain circumstances. The other notice of enforcement discretion is also really important because it's for business associates to share information directly with public health authorities. So HIPAA business associates on their own don't have the right to do that under the HIPAA privacy rule. It has to be spelled out in their business associate agreements. And so again, here the government is saying, we think it's important to understand that business associates like telehealth vendors, like EHR vendors, like HINs and HIEs, like other entities that work very closely with healthcare providers, have a lot of really important data about this crisis. And it may be that they need to share that data with public health authorities who are authorized by law to collect that data. Because they don't have the right to do that unilaterally under the HIPAA privacy rule, the government has said in these cases and in certain circumstances, these business associates are allowed to share that information unilaterally, but they have to notify the HIPAA covered entities with which they work, whose data it is, what they're doing with that data, and there may still be contractual remedies for those entities that disagree with that approach. So again, what they want to do is use their discretion to not enforce particular provisions of the rules to the extent that there are circumstances where we really do need to share this information in a way that is otherwise permitted for other entities under the rules, and in a way that ensures that everyone's involved in that conversation. So obviously many other circumstances that the government is dealing with here during this crisis in terms of sharing the information, but those are two of the most important, I think, to highlight.
Thank you very much, Iliana. Just a reminder to our audience members, if you have questions about the interaction of EHRs and the COVID-19 crisis, you can ask those questions through the Q&A chat window at the bottom of your screen. But in the meantime, I have some quick follow-up questions as well. So Iliana, I was wondering, do you see further guidance on privacy coming down the pike? And on what issues do you see that guidance focusing on?
Yeah, I think it's a great question. I mean, there has been a lot of additional guidance in other bulletins by OCR that provides additional information about how healthcare entities can share information with family members and friends of individuals who may be in crisis or otherwise, who are involved in their treatment. Also, in terms of how we can share information during this crisis with public health authorities that are authorized by law to get that information, or with law enforcement in certain circumstances. The privacy rule does permit that kind of sharing, the HIPAA privacy rule, in certain circumstances. But there's also been a lot of warnings coming out. So, we've seen warnings from HHS about people posing as investigators for the government during this crisis and calling and asking for information. We've seen warnings about the security issues with different technologies that people are using during this crisis. So I do expect certainly to see more of that from the government, because I think, as we move through this crisis and people are trying to understand the circumstances related not only to our health, but also related to, the ongoing crisis in terms of those individuals who might take advantage. So there are still, daily issues related to different types of cyber attacks, to different types of security controls. All of us working remotely is a fantastic thing in so many ways, but it's also a security nightmare in a lot of ways too. So, I think at the very least, what we will see coming out from the government is additional information about not only how we can be sharing information in better ways, but also in the best ways possible from a data privacy and security perspective.
There is a question from the audience, which states that their understanding is that the allowance for business associates to share data directly with public health does not change the requirement to respect minimum necessary provisions related to non-treatment related disclosures. Is that correct?
Absolutely. So again, here we have a situation where the business associate, if they do in fact share information with a public health authority, they have to comply with all the other requirements of the rules. And that is minimum necessary, that's safeguards, that's a security rule requirement. So we're looking for encrypted transmissions, we're looking for access controls, everything else that would otherwise apply under the privacy rule. It is just the piece that these entities now may directly undertake the sharing of that information with notice to their covered entity clients, rather than having to check with the covered entity client first before they do so. Oh, I think you're on mute again.
Another question also on privacy is, so most counties are reporting COVID-19 numbers daily, but some counties in California are claiming that privacy is preventing them from reporting COVID-19 cases. Is there some ambiguity or a need for guidance from HHS?
You know, so much of this has to do with the state law. So again, the HIPAA privacy rule allows for the sharing of information related to public health to entities that are authorized by law to collect that information. And it's limited to the information that is prescribed by that law to be shared with that entity, state, federal, civil, tribal, whatever the circumstances may be. So again, it may be that there are certain provisions that apply under a specific state law that limit what information can be shared and with whom. And certainly the rules will defer to that on the federal level. So often we see that in other circumstances like breach notification. You know, the state laws could differ greatly with regard to notification in the case of breach. Very similarly, they differ greatly across states with regard to protections for the underlying information itself.
Thank you. Now a question for Mr. Yaraghi. So states' actions on telehealth have been made by executive agencies, but the underlying statutes remain the same as before. Do you expect legislatures to make permanent changes that liberalize telehealth and or licensing of professionals?
I think so, because you know, you cannot talk about innovation and changes in the healthcare system without talking about privacy. And Iliana has been you know, talking about all of these great points, which I agree with all of them. And going forward, I do believe that these changes will come, and that would also require a careful examination of HIPAA and other privacy regulations that may be in place when it comes to expanding telehealth services, because that is a very general term. You know, are you going to only have a meet office visits virtually with your physician, or does that mean that some other people, like just like this Zoom meeting, can come in and listen in maybe for so all of these I think requires agile reaction from the government and policymakers when it comes to you know, updating the privacy regulations that we have, in order to do two things at the same time and make a balance between them. The very first one is to make it possible for these innovations to emerge, and the second one is to protect the privacy of the patients. And to be honest with you, I'm a little bit worried about the second one. I think we have gone into such a panic mode that we're just forgetting about many things. And although as a person who's involved in health IT, I'm happy that all of these innovations are coming through and we're exchanging data in such great terms. But I'm a little bit concerned and worried for patient privacy. You know, now we have all of these changes that Iliana mentioned because of the special times that we are at. But when you look at the reactions of different states to the same phenomenon, you see it's very, very different. You know, some states have taken it much more seriously than others. And at the international level, when you look at it, countries have taken it very, very differently. So the question comes to my mind that, you know, going forward, how are we going to define an emergency situation? What is an epidemic? Can we define a flu as an epidemic and say that let's just forget about all of these privacy rules that we have, and let's make these exemptions that we have put in place only for COVID-19 to continue and make them permanent? I think we shouldn't. And at the same time, I think we should be, you know, considerate to the innovation side and make sure that we maintain necessary regulations that you know, protect the privacy of the patients.
Absolutely. Thank you so much, Niam. So there are some other great questions in the Q&A, but unfortunately we don't have time to get to them. I'm just going to conclude with a question to Anne and give the doctor the last word, which is, Anne, what other tools would you like to see in your toolbox to deal with this crisis?
I mean, given we've talked a little bit about interoperability, I think that that is one of the things that we still have a lot we could be doing with. You know, within Epic, we're doing a great job of benchmarking and sharing data, and most of us have signed additional agreements with Epic to share back things like how many ventilators we have available, how many ICU beds we have available. And so we can actually benchmark at a local level and at a national level against other organizations to see where resources are. What we don't have is a great way to do that throughout the whole country. You know, and this is where HIEs and other places, if we could get there, would give us that good national picture without everyone having to report data to some spreadsheet that then publishes it out. I think one of the things I learned a lot as we stood up our COVID testing, we've had probably 20 different versions of the test in our system. And as people result it, they result it differently. So the people in the lab are resulting these as either abnormal or not abnormal, detected or not detected. And even just trying to pull the data in my own system about which patients are positive and which ones aren't, I can't get there. And so because this was such a rushed thing that everyone is dealing with, I fear that even with interoperability, getting that data at a national level would be difficult because I can't get it out of my own system because there was no standard in which we were putting it in. And so I think that these are opportunities in places that we need to think about in the future of how we can actually standardize this stuff enough that we can have true interoperability to drive patient care at the public health level and at the national level.
Thank you so much for that, Anne, and thank you so much to all of you. I can't tell you how grateful I am for you coming on board in such short notice. This was truly wonderful, and I'm sure these conversations will continue for days to come. And thanks again to the audience members for your fantastic questions. We'll now transition to our next panel, for whom the moderator will be the wonderful Iliana Peters, and we'll convene in about 3-4 minutes. Thank you.
Thank you very much.